Okay, let's unpack this. If you or someone you know is navigating menopause, well, you know that the decline in hormones can cause some incredibly frustrating physical changes.
Oh, absolutely. It really affects quality of life,
Right. But what if the treatment for those changes didn't involve flooding your entire body with a heavy dose of systemic
which
hormones?
is the traditional route. Yeah.
Exactly. What if instead the treatment relied on something called intracrinology, where your own cells are essentially handed the blueprints to act like local manufacturing plants?
It completely shifts how we approach the problem,
Yeah.
because instead of a systemic overhaul that affects every single organ, we are looking at precision delivery.
Just targeting the exact tissue that is actively degrading.
Exactly. Targeting only the tissue that needs it.
So today's deep dive is all about a treatment called Prasterone. Specifically, we're looking at localized Prasterone inserts used to treat genitourinary syndrome of menopause, which is often called GSM.
Right, GSM.
And we are pulling from a massive stack of research today. I mean, we've got global data from the FDA, European Medicines Agency documents, UK prescribing guidelines, and some incredibly dense peer-reviewed tissue studies. We really want to figure out how this actually works.
Yeah, our mission today is to move past the, basic surface level understanding of this treatment.
Definitely.
We are going to focus on the clinical guidelines, but more importantly, we need to understand the complex role of nerve fiber changes in vaginal atrophy.
Which is fascinating, by the way.
It really is. Because it isn't just about what this medication is, it's about how it literally remodels the physical structure and the nervous system of the tissue itself.
So before we get into the wild world of nerve changes, let's establish what this treatment actually is. The brand name you'll often see is Intrarosa.
Yes.
It is a once-daily 6.5 milligram vaginal insert, or pessary, and the active ingredient is the synthetic equivalent of endogenous DHEA, which stands for dehydroepiandrosterone.
Try saying that 3 times fast.
I really won't. But DHEA is naturally the most abundant steroid in the human body, right?
It is, yeah. But the critical piece of information here is that prasterone is totally inactive on its own. It's a precursor molecule.
Wait, if it's an active, how is it a treatment? Like it's just sitting there?
Well, this is where that concept of intracrinology comes into play.
Okay.
When this inactive precursor is inserted locally into the vagina, it gets absorbed by the local cells. It doesn't do anything in the bloodstream.
Oh, I see.
Instead, inside those specific vaginal cells, local enzymes go to work and actually convert it into active androgens like testosterone and estrogens.
Wow. The analogy that pops into my head here is like a Trojan horse.
Oh, that's a good way to put it.
Yeah, like Prasterone is a medical Trojan horse, but instead of soldiers waiting to attack, it's delivering raw chemical blueprints directly into the vaginal cells. It slips inside, and then the tissue uses those blueprints to build exactly the hormones it needs, right where it needs them.
That is a highly accurate way to visualize it. I mean, it's on-site manufacturing. And the beauty of this cellular factory is the waste management system.
The waste management.
Yeah, so the hormone is synthesized, right?
Yeah.
It does its job to repair the cell, and then it is inactivated intracellularly, meaning completely inside the cell itself.
Oh, wow.
Then the waste products are excreted by the kidneys and liver as inactive conjugates.
Inactive conjugate. So basically cellular exhaust that the kidneys just filter out into your urine.
Precisely. And because the hormones are created and then destroyed within the closed loop of that local tissue, the blood absorption is essentially negligible.
That's incredible.
It is. The clinical trials, including a major 12-week study with, I think, over 700 women, showed that serum steroid levels, the hormones in the bloodstream, remain safely within normal postmenopausal limits.
So you aren't seeing a systemic hormone spike that might affect, breast tissue or the cardiovascular system.
Exactly. You get the local fix without the full-body flood.
Okay, so now that we understand how the cells get these hormone building blocks, let's look at what physically happens to the tissue structure. Our sources dive deep into the nerve fibers and atrophied tissue, and there is a detail in the research here that seems completely counterintuitive.
Ah, yes. The nerve fiber paradox. What's fascinating here is that when you look at human studies comparing vaginal tissues, you would logically expect healthy, thick tissue to have a really dense network of nerves.
Yeah, and atrophied, unhealthy tissue to have fewer nerves, right?
Right. But the research shows the exact opposite.
Right, really?
Yeah. Women with severe atrophy, meaning virtually no estrogen exposure, actually had the greatest density of autonomic and sensory nerves in the vaginal submucosa.
Just to clarify for anyone who hasn't looked at an anatomy chart recently, the submucosa is the layer of connective tissue right under the surface lining, correct?
Yes, exactly. It's the supportive layer that holds all the blood vessels and nerves.
So the thinnest, most degraded tissue actually has the highest number of nerves packed into it.
Yes, it does. And when they looked at women using systemic estrogen, the nerve density was moderate. It was lowest in women using topical estradiol.
Hold on, I'm looking at another source here. There's a study on overectomized rats. I'm guessing overectomized means they surgically remove the rat's ovaries to simulate human menopause.
That is the standard laboratory model for studying sex steroid deficiency, yes.
Okay, so in that rat study, applying DHEA actually increased the density of certain nerve fibers in the vaginal wall.
Right.
So how does that make sense? Because in human studies, severe atrophy meant more nerves. But in the rat model, treating the atrophy with DHEA added even more nerves to the tissue. Are we just adding nerves to a place that already has too many?
So what's really key here is that it's not just about the absolute total number of nerves. It's about the type and function of those specific nerves.
Okay.
When a postmenopausal woman experiences severe vaginal atrophy, that high density of nerves we see in the human studies includes a massive overactivity of nociceptors.
Nociceptor, those are pain receptors, right?
Yep. Yes, exactly. Because the tissue is starved of hormones, it becomes incredibly thin and inflamed. Those pain signals are basically dialed up to 10, firing off constantly.
Ugh, that sounds awful.
It is. That is what causes the burning, the itching, and the severe pain during sex, which is known clinically as dyspareunia. The tissue isn't healthy, it's just completely hypersensitive.
So it's like a security alarm that's glitching and constantly blaring, even when there's no actual intruder.
That's a great way to put it. Now let's look at the rat study with DHEA. The researchers in that study weren't measuring those glitching pain receptors.
Okay, what were they looking at?
They were looking at very specific physiological markers, one called PGP 9.5, which is a panoronal marker, and another called TH, which marks sympathetic nerves.
Got it.
Essentially, they were using biological highlighters to trace a completely different set of wiring. And they found that DHEA increased autonomic innervation.
Autonomic nerves. So we're talking about the involuntary stuff, right? The
Yeah.
nerves that handle automatic body processes. I imagine getting more blood to that tissue is exactly what prevents the thinning in the first place.
You've hit the nail on the head. In the vaginal wall, increased autonomic innervation directly and positively influences the vascular supply.
Okay.
It tells the blood vessels to dilate, bringing in oxygen and nutrients. It also regulates tissue mass and smooth muscle tone.
So the DHEA is stimulating the growth of the functional, healthy nerves that keep the tissue thick, elastic, and well lubricated.
Precisely. This healthy nerve growth is completely distinct from those overactive pain receptors that cause so much misery.
So the Prasterone isn't just acting as a, topical moisturizer masking the pain. It is fundamentally remodeling the physical scaffolding and the functional nerve supply of the area.
It's essentially rebuilding the foundation, yeah.
That makes perfect sense. And it really clarifies why the clinical benefits we see in these sources go so far beyond just basic pain relief.
The structural changes are profound. I mean, the primary FDA indication for Interosa, which was approved back in 2018, is for moderate to severe dyspareunia related to vulvovaginal atrophy.
Right.
It decreases pain, it lowers the vaginal pH back to a healthy acidic level, and at a cellular level, it completely changes the cell population.
No, how?
It increases the healthy superficial cells while significantly decreasing the peribasal cells.
Let's break down those cell types for a second. Peribasal cells. Think of them as the immature, fragile cells that usually live deep in the tissue, right?
Yes.
So when the tough outer layer wears away because of atrophy, these fragile cells just get exposed to the surface.
Yeah, exactly. And they aren't meant to handle friction or a harsh environment. Prasterone basically allows the tissue to mature those cells into tough, healthy superficial cells again.
Which naturally leads to an interesting pilot study mentioned in the IRS database. It looked at 32 postmenopausal women with overactive bladder syndrome, or OAB.
Oh, yes, the OAB study.
At first glance, a vaginal insert fixing a bladder problem sounds like a massive stretch.
It sounds like a stretch until you look really closely at the anatomy. Women with genitourinary syndrome of menopause frequently complain of overactive bladder, urinary urgency, and recurrent urinary tract infections.
So they're definitely connected.
Very much so. The connection is the embryology. The lower urinary tract, meaning the bladder and the urethra and the vaginal tissue, share the exact same embryological origin.
Okay, wow.
They are essentially the same continuous sheet of urogenital mucosa.
Meaning they both rely heavily on estrogen and testosterone to stay healthy.
Exactly.
So if the vaginal wall is starving for hormones and thinning out, the urethra and the base of the bladder are naturally starving and thinning out too.
That's it, exactly. The bladder sits right on top of the vaginal wall. When that wall thins out, it loses its shock-absorbing capacity.
Oh, that makes sense.
The nerves around the urethra become exposed and hypersensitive, just like those glitching pain receptors we talked about earlier.
Right, the alarm system.
Yes. And that physical irritation makes the bladder feel like it constantly needs to empty, even when it isn't full.
That makes the results of this pilot study so much more logical. After 12 weeks of using the 6.5 milligram Prasterone insert, these women saw their incontinence questionnaire scores drop dramatically, from an average of 7.8 down to 2.7.
Which is a huge improvement.
Yeah, and to put those numbers into perspective for you listening, a 7.8 on an incontinence scale often means waking up multiple times a night, planning your day around where the nearest bathroom is, and experiencing significant anxiety about leaking.
Takes over your life.
Totally. So dropping to a 2.7 is life-changing. It means sleeping through the night and going to the grocery store without panic.
It restores a baseline of normalcy. And the studies on broader functional improvements didn't stop with the bladder. Another major clinical trial looked at female sexual dysfunction, or FSD.
What specifically were they looking at there?
They examined domains like desire, arousal, orgasm, and lubrication.
And they found significant improvements across all those domains, right?
They did, yeah.
But there's a detail in that FSD study that really stood out to me as counterintuitive. Those improvements in sexual function occurred regardless of whether the woman had moderate or severe pain at baseline.
That is a pivotal finding in the literature. Historically, the medical community assumed that postmenopausal women experienced a drop in sexual desire and arousal simply because sex was physically painful.
Right, the logic was just, if it hurts, you won't want it.
Which makes sense on a human level, definitely.
It does.
But this study suggests something much more nuanced. It shows that vulvovaginal atrophy and sexual dysfunction are actually two independent consequences of sex steroid deficiency.
Okay, so you don't have to be in severe pain to benefit from the physiological improvements Prasterone brings to arousal and lubrication.
Exactly. The local testosterone production specifically plays a huge role in the nerve pathways related to arousal, completely independent of the pain receptors.
Now, I do want to play devil's advocate for a second regarding the statistics in that FSD study.
Go for it.
It mentions a 2.59-point improvement on the Female Sexual Function Index scale, which is a 36-point scale.
Right.
And the source explicitly notes that you usually need at least a 10% difference for a result to be considered clinically significant in the real world. So as someone looking at the data, I have to ask, does the 2.5-point bump actually move the needle for a patient's daily life? Or is this just, statistical noise that looks good in a medical journal?
If we isolate just that single metric, it's a very fair critique. A 2.59-point increase on a 36-point scale seems pretty modest.
Yeah.
But you have to look at the holistic impact on the patient to see the real story. If we connect this to the bigger picture, the IRIS study also measured quality of life using something called the SF-12 Health Survey.
The SF-12, that's a general health questionnaire, right?
Yes, it assesses both mental and physical health. And after 12 weeks of Prasterone therapy, the women had statistically significant improvements in both their mental health scores and physical health scores.
Oh, wow, okay.
So while the exact percentage jump on one specific sexual function index might seem borderline to a strict statistician, the actual patients are reporting profound, measurable improvements in their overall well-being.
Because when you remove constant vaginal irritation, eliminate urinary urgency, and improve tissue elasticity, the overall quality of life naturally skyrockets.
Exactly. It's the cumulative effect.
So if the cellular factory works so flawlessly to rebuild tissue and calm these overactive nerves, why isn't every postmenopausal woman using it?
Well,
that brings us to the catch, right? The practical reality of how you actually have to administer this, the clinical guidelines, and the financial hurdles.
the practical reality is undeniably the biggest hurdle for a lot of patients. Unlike a systemic hormone pill that you just swallow with your morning coffee and forget about, Prasterone requires a daily physical routine.
And the guidelines are very specific about this. It requires daily insertion at bedtime. You have to wash your hands, use a disposable plastic applicator to insert the 6.5 milligram pessary deep into the vagina, and then dispose of the applicator.
It's a whole process.
Yeah, it requires a certain amount of manual dexterity, and quite frankly, it requires commitment.
And the clinical guidelines are incredibly strict about that consistency. Because this treatment relies on feeding raw materials to a local cellular factory, you cannot cut corners.
You can't just skip a few days.
No. The sources note that decreasing the dose to twice weekly significantly diminishes the effects. The tissue needs that daily delivery of Prasterone to maintain those autonomic nerves and the structural scaffolding.
The Southeast London IMOC guidelines, for example, frame this as a continuous maintenance therapy, right?
Yes, continuous.
Let's talk about those guidelines and the cost, actually, because the financial burden varies wildly depending on where you live.
It really does.
In the UK, the Southeast London IMOC guidelines recommend it for postmenopausal women with moderate to severe symptoms. And the cost to the healthcare system is quite manageable. It's around £10.47 for a month's maintenance.
Now compare that to the United States, where the estimated retail price for a month of treatment is often cited around $210.
That is a massive discrepancy.
Huge. Even with insurance, copays in the U.S. can make a daily, long-term treatment like this inaccessible for many women.
And as for how long you can use it, the UK license duration is a maximum of 2 years, though our sources note it's very often used long-term off-label. I'd imagine that's because if you stop supplying the raw materials, the cellular factory just shuts down and the atrophy comes right back.
Exactly. It doesn't cure menopause. It manages the tissue health locally as long as it's applied.
Okay, what about tolerability? We know it avoids systemic hormone spikes, but are there local side effects?
It is generally very well tolerated. The most common side effect reported in the trials was vaginal discharge.
Which makes sense given that a solid insert is dissolving in there daily.
Right. And that affected about 2.7% of users.
But there are some serious safety watchouts we need to cover. In a 52-week clinical trial, 2.1% of users developed abnormal pap tests, specifically ASCUs.
ASCUS stands for atypical squamous cells of undetermined significance.
Which sounds terrifying to a patient. Basically, it means slightly weird-looking cells showed up on a cervical swab, right?
Yes. Now, the context here is crucial.
Okay.
That 2.1% incidence rate is actually very similar to the rate of ASCUS in postmenopausal women who aren't using the drug at all.
Oh, really?
Yeah. However, think about what this drug does. It stimulates rapid cellular growth and turnover, maturing those fragile parabasal cells into superficial cells.
Right, it's rebuilding the tissue.
When tissue is rapidly regenerating like that, it can sometimes shed a cell that looks atypical under a microscope, which triggers that ASCUS result.
So it's usually a sign of tissue regeneration, not cancer.
Exactly.
Yeah.
But because of that finding, clinical guidelines suggest patients using Prasterone might need additional surveillance and follow-up pap tests just to be absolutely safe.
Good to know. And there are clear contraindications where it shouldn't be used at all. You cannot use this if you have undiagnosed abnormal genital bleeding.
Sure.
And crucially, the FDA carries a warning against using it if you have a history of or known or suspected breast cancer.
That is a standard precaution across the board for hormonally driven therapies.
Even local ones.
Yeah. There is simply minimal safety data on how even these localized intracrine hormones might interact with hormonally sensitive malignancies. Even though we know the serum levels don't spike, the medical community takes a highly conservative approach with breast cancer survivors.
It's a reminder that no treatment is one size fits all, and having a highly specific conversation with an oncologist or gynecologist is non-negotiable.
Always.
Okay, let's take a breath and recap the journey of this deep dive. We started by exploring the localized Trojan horse delivery of endocrinology, how Prasterone delivers the raw blueprints for your cells to manufacture their own estrogen and testosterone directly on the factory floor without flooding your bloodstream.
And then we untangled the nerve fiber paradox.
Which was so interesting.
Right. We discovered that Prasterone doesn't just act as a topical soothing agent. It actively promotes the growth of healthy autonomic nerves that restore blood flow and elasticity.
This physically counteracts the overactive, glitching pain receptors that dominate in severely atrophied tissue.
Exactly. And we saw how those fundamental structural and nerve changes create a ripple effect throughout the entire pelvic region.
Because the vagina and the lower urinary tract share the same structural tissue, rebuilding the vaginal wall also improves overactive bladder symptoms, and it drives significant improvements in overall sexual dysfunction, totally independent of just resolving pain.
Right. And finally, we grounded all of this in the clinical realities. The rigid daily commitment it takes to use the applicators, the massive cost disparities globally, and the importance of clinical surveillance like pap smears.
For you listening, this is exactly the kind of deep mechanistic knowledge that empowers you as a patient. If systemic estrogen isn't an option for you, or if standard over-the-counter lubricants just aren't cutting it because they only address the surface friction, well, you now have the vocabulary and the science to ask your healthcare provider about endocrinology,
Yeah.
localized DHEA, and treatments that actually rebuild the tissue based on these specific clinical guidelines.
As we wrap up, I want to leave you with a broader physiological thought to chew on.
Okay.
We've just spent this time marveling at how vaginal tissue retains this incredible latent capability to flawlessly convert raw precursor molecules into exactly the hormones it needs locally and safely, utilizing its own cellular exhaust system.
Right.
This raises a fascinating question about the future of medicine. If this localized cellular factory mechanism exists here, what other age-related conditions, from skin aging and losing elasticity to joint deterioration and cartilage loss, might we one day treat not by flooding the entire body with heavy systemic drugs, but by simply delivering the raw blueprints straight to the local cellular factory floor?
Now, that is a thought that changes how you look at the human body entirely. Thanks for diving deep with us today.